Welcome everyone to today's webinar. I'm Emily Rapley with Becker's Hospital Review. We will begin the webinar today with a presentation and we'll have time at the end of the hour for a question and answer session. You can submit any questions you have throughout the webinar by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. We look forward to hearing your questions. Additionally, in about a week following the webinar, we will send a copy of the recording to the email you used to register. At this time, it is now my pleasure to start today's webinar by introducing our presenters. Beth Hankey-Just is a nationally recognized patient matching industry expert and founder and CEO of Just Associates, a healthcare data integration consulting firm. She served on the AHIMA Board of Directors, served in numerous state and national positions, and currently serves on the College of St. Scholastica's Board of Trustees. Her state professional association has awarded her the Distinguished Member and Lifetime Achievement Awards. She frequently speaks at national and state professional association meetings and has published over 40 articles and papers in several healthcare journals. Erin Meary has held leadership roles in health IT for over a decade, most recently as a provider healthcare system CIO. As CIO of Imprivata, he is responsible for leading the vision, development, and implementation of information technology initiatives in support of Imprivata's overall business plan and strategic vision. Mr. Meary has a wealth of experience leading IT organizations in support of driving innovation in healthcare, most recently as CIO of Walnut Hill Medical Center, which was lauded by Forbes magazine as the hospital that Steve Jobs would have built. He holds a Bachelor of Science in Management Information Systems from the University of Texas at Arlington and a Master of Business Administration and Healthcare Services Management from the University of Dallas. Erin, I'll now turn the floor over to you.
Thank you very much. I appreciate that. And hello to all of you listening. Thank you for tuning in today. I can tell you on a personal note that I worked with Beth many years ago as a CTO at a pediatric hospital, and her and her team know their stuff. So you guys are in for a treat as listening to her. So today we're going to talk about a few things that are near and dear to my heart. And I'm going to layer in some personal examples from my previous lives in both peds and adult care, as well as over the past year, as I've been within Imprivata, working with providers around the globe, some of the things we're seeing, particularly in this country. So a couple of things. One, first and foremost, the challenges and the consequences of manual patient identification. What a pain it is today to identify a patient, especially taking the case of a pediatric hospital where you're having all kinds of kids of all kinds of conditions come in and trying to figure out who is baby boy John or baby girl Smith. Number two, we'll look at the causes for duplicate and overlay records. Look at the reason why, two Erin Meary showed up, registered at a hospital, and you have two medical records to try to figure out which one is legit and which one is not. Then we'll go into best practices for EMPI and MPI cleanup, and we'll talk about the improving patient matching across disparate systems, how to do that. If you guys haven't read the latest Pew Charitable Trust white paper, you should. It showed that some mismatch rates across systems are of up to 50%. I've been at previous places where it's been higher than that. But there's significant steps that can be done to ensure that each patient has one record, and we'll talk about that. And then finally, we'll talk about leveraging patient photos and biometrics to improve patient identification and really ensure accuracy and records matching. All right, so first and foremost, it all starts with the patient. If you guys saw the latest market news come out today that Congress is considering a national patient identification strategy and layering it out in the funding bill, there's even potentially a mandate that's going to be there for the hospitals that participate in Medicaid to use patient matching technology. That's an amazing announcement this morning and speaks to, just timely why we're doing this webinar. It's a national issue and an international issue. So again, it all starts with the patient. Before providers can access a patient's health record, they must ensure it's a correct record. So this is happening way too often. On average, 7 to 10% of the patients out there are misidentified. In fact, ECRI found that 9% of these misidentifications result in an adverse event, doing harm. Think about it, 9%. So if we're harming almost 1 in 100 patients due to misidentification, think about that. That's almost 9,000 adverse events for 1 million opportunities. I don't want to get too math wordy here, but in my perspective, doing harm to one patient because you just didn't do your due diligence is unacceptable. So let's look at this in terms of what's going on today from manual processes and why those are resulting in significant safety concerns and rev loss. We're seeing our customers struggle with the following issues. Number one, medical errors and sentinel events. Number 2, duplicate and overlaid medical records. Number 3, revenue loss and denied claims and the associated financial ramifications of misidentification. I think anybody who is a health information management professional or in the business office or whatnot can probably list off their organization's claims that are stuck in adjudication simply because you could not prove or you misidentified the patient where you were submitting the information. And then last but not least, and one especially that was near and dear to my heart because we had a major issue with this in the market I was in, is identity theft and insurance fraud. So today's hospitals have put in place a multitude of different processes and protocols. And I'll tell you, especially the HIM professionals, they do a hero's job. Some of them have a small army working to do this. And some of the solutions they've put in place historically have been things like checklists, scripting, naming policies and best practices in searching for patients. Sometimes even hospitals will get together and partner up and come up with a special buddy system or code system to put on the medical records to lump MRN numbers together. Unfortunately, all of these are prone to human error and have limitations of whatever respective technology is involved. It can be really difficult for the registrars to find the correct chart by asking a list of questions of patients or families. And especially, I mean, how many times I saw this in pediatrics, a very troubled mom or dad brings in their kid who's very sick. They want to get their kid seen. They're not worried about making sure that the street address is accurate, or you know what? Maybe you misspelled Johnny's name and you put an H instead of an O. Who cares? Get him in. I want him to be seen. And that throws everything into havoc. Everything downstream is off, and now that kid has another medical record potentially, and that's where at the end of the day it's a bad issue. Also, anybody in the ER knows how hectic this is. You know, patients and family members under stress could be hard of hearing, confused. Language barriers, could be a trauma situation, in which case the person's unconscious. I mean, what do? You know, different people also have different cultures and naming conventions, especially, again, I was in the market and top 10 market. We had folks come in from all socioeconomic regions of the world, and I couldn't try to pronounce or spell their name if somebody paid me to. These are the things that happen in real world hospitals that is just becoming way too burdensome for existing processes and conditions. All right, so let's talk a little bit more about the traditional processes. So registrars, we have found, are incorporating checking some form of ID when looking at the patient in the system. Usually they'll scan the ID to the medical record, and it's a nice black and white glossy that maybe or maybe not was scanned right. I got so many phone calls in the middle of the night from our poor registrar saying, hey, this license won't scan, and it was from somewhere in the world and they didn't know. I mean, they'd have out-of-state addresses, different formatting. Sometimes it's not even the right ID. I just borrowed mom's because I want to get in the car and get there. All these things are occurring. Well, a lot of that's changing under MACRA, and a number will no longer be available for search procedures. And in addition, some of the registration systems and EMRs have character limits or different standards. And again, this is all adding to dupe records, especially if an organization has more than one ADT system. It's common. A lot of times, what you're also seeing is because of a lack of standardization and because it's so much data input, the registrars and the folks getting the information into the system just don't have the time. They've got a queue of 30 people waiting in the ER that need to be seen, and every minute counts, especially in healthcare. So all of these things lead to misidentification. All right, patient safety. Every one of us that's been in healthcare has dealt with Joint Commission, CMS, going through numerous patient safety issues, items, sentinel events, near misses. How many of us have sat in on a quality call, at 8 in the morning huddle to figure out what happened the night before? It's just there. It's what happens. Looking at this slide, this tells you straight up that the ECRI Institute said that patient identification is the #2 largest patient safety concern for hospitals of last year. And 9%, we said this earlier, percent of patients who are misidentified suffered an adverse event. Well, that would lead to why it's #2. The Ponemon Institute came up with a report late last year that had registration errors the #1 cause of misidentification. 86% of clinicians stated they have witnessed medical error for misidentification. I personally think the other 14% maybe we're trying to be nice about it because this happens way too common in the healthcare setting. 31% of denied claims result from misidentification. Again, I would say it's probably higher because that's 31% of claims outright realized it was denied for misidentification, not those stuck in adjudication that they're trying to figure out what's wrong with this thing. So looking at some of the Joint Commission stats and Sentinel events, right? Again, these are all stats that are publicly available. You know, Joint Commission's come up with wrong patient, wrong site errors of 1,200, medication errors. I'm not going to read every one of these, but the bottom line is improving accuracy of patient identification is the #1 priority for the Joint Commission. I mean, when they show up at your hospital and a surveyor shows up, every one of us as a healthcare provider knows it's all hands on deck, make sure that they have what they need. If we're not getting our arms wrapped around this, we're doing a disservice not only to the hospitals that we serve, but to the patients that are there in the time of greatest need. We've got to do better. All right, medical errors and misidentification. 27% of all radiation errors, 29% of all medication errors. I mean, blood transfusion errors. This is, again, I don't want to think that we're spreading FUD. These are legitimate stats that are out there. And from all of us that have been in hospitals know that this has to be dealt with. There's also liability with all of these, and it's just a messy situation. Rev cycle issues. I had a CFO once tell me, he said, Aaron, cash is king. And I really appreciated that because it really spoke heavily towards making sure that you get your processes straight up front and your back office straight. And how we have so many manual processes today layering in dates into that really adds more and more complexity to this, which messes things up downstream. So rev cycle functions often represent the first and last interaction with the patients. It could be anything from financial counseling all the way through upfront, making sure you get the information right. So a seamless, stress-free experience is important. And not only that, a seamless billing process. So these are, patient-friendly financial processes that can positively impact your HCAHPS score. And now, of course, Medicare ties back reimbursement to value-based purchasing. But if you're looking at this, there are billing errors, insurance information, billing address, all of these items we've seen from our customers have been positively assisted with by streamlining and by layering in technology. And we're going to get into all of those kind of items. All right, so I'm going to turn it over now to a big expert in this industry, Beth, and Beth, it's yours.
Thank you, Aaron. So how does misidentification happen? I'd like to set the stage for kind of common terms that are used in misidentification of patients. Duplicates, Aaron's talked about, where one patient within one system has more than one medical record number and therefore has more than one medical record. So the clinician is treating that patient with incomplete information. Overlaps, or sometimes called crossovers or linkages, are where one person within a large enterprise or like a health information exchange or an accountable care organization has more than one record within that larger health system. So they might not have a duplicate medical record number within an entity, but once they link up at like a corporate level, enterprise level, HIE level, ACO level, et cetera, they've got more than one record. And so again, their clinician who might be accessing that system has got incomplete information. An overlay is a very serious event where two different people's information has gotten commingled into one record. And this, we're seeing higher and higher incidence of this occurring as databases get bigger and the data collection is having to be more expedited, and like Aaron mentioned, especially in emergency rooms or pediatric institutions and things like that, where they're really trying to get these people in the door quickly. Registrar grabs the wrong record and now they've commingled two different people's records. Next slide. So how did the data get so dirty? It's certainly, I've been in this profession a long time, and we're certainly seeing higher and higher rates of duplication and overlaid medical records. And certainly some of the common underlying causes are data conversions and new system implementations, downstream systems that are not kept in sync with that primary system, and then they send the result back, and so it dirties the system, the source system back up again. Lack of standardization. There's certainly a lot of healthcare technology standards out there, but they are not all deployed consistently and completely, and certainly not every organization and every EHR system or whatever is out there is at the same level of compliance with a particular standard. Common, probably the most prevalent problem is just simple data entry errors. You have people that have, you know, a friend of mine, his name is David Mark. Well, obviously he gets called Mark David all the time. So name swaps, use of default data in data fields like birth dates and socials. Those types of errors are probably the most prevalent cause of dirty data in your systems. Incomplete data is a huge problem, especially when you're dealing with reference labs, where if you have a lot of reference lab information coming into your system, a lot of times all they collect is a first name, last name, date of birth, and gender, and the ordering position. And that is simply not enough to identify that that's the same John Smith as what you're trying to connect that result to. And lack of historical data quality maintenance and cleanups. You know, in other industries, even like retail companies, I mean, they scrub their data every couple of years, and they do it so they're not sending out extra catalogs to the same address. I mean, they're doing it for, you know, financial reasons, and it's a very common practice in other industries to scrub your data and clean it up. Next slide. So obviously, patient matching, the goal is to ensure the accuracy of every patient's identity and making sure that their information is available wherever, whenever care is needed for that particular individual. And I've talked with people that just say, I don't get why this is such a hard problem. Why can't you identify a patient easily? Just ask them their name or just ask them their date of birth. But it's a much more complex situation when you start digging into what causes the challenges of inaccurate patient matching or patient identification. We don't have a good, strong national patient matching strategy, although I will say that the ONC, and as Aaron mentioned earlier, Congress is now considering it. We are starting to get movement on that, so that will help. One of the biggest problems is that demographic data, which is what is used for most patient matching and patient identification, that frequently changes. First names can change, last names change, people move, they change telephone numbers. They won't provide their social security number anymore. Genders change. I mean, really the only thing on an individual that will never change is their birth date. And then you go to other countries and they don't know the birth date. That's not always, in some countries, a cultural effect that where they are actually collecting a date of birth for a patient they don't know. So demographic data is a big challenge. Multiple demographic data points are needed to make a successful match. Like I mentioned earlier, last name, first name, date of birth, and gender is simply not enough to uniquely identify that patient. Not when you have databases with millions of records in them, and they might have 2,000 Jose Rodriguez's in their database. And guess what? Probably going to be somebody with the same date of birth, or two different people with the same date of birth. The data ownership issue in provider organizations, there's lots of stakeholders, everybody's got a voice in that use and how data is collected and used. So that makes the issue more complicated. And certainly users and organizational processes across different organizations are not consistent and not the same. Next slide. So the ONC published a report about a little over 3 years ago, and they did an environmental scan and surveyed over 100 organizations, provider organizations, very large organizations, and found that the mean duplicate rate was 8%, and a quarter of those had duplicate rates of greater than 10%. AHIMA, which is the National Professional Association for the Health Information Professionals, did a survey, and most respondents reported that they have greater than 8% duplicate rate, and a third of them said they had anywhere between 8 and 14. And that's duplicates within the system, within that same organization. Cost of duplicates, there's been quite a bit of work on that. Mayo has reported misidentification mistakes cost at least $1,200. Some cost hundreds of thousands of dollars. Intermountain reported the cost just to fix the duplicate at $60 for each duplicate. Next slide. There was a study that was done by the EMPI data integrity manager at Sisters of Charity in Denver, and he did his a research paper for his master's on overlaid records. And so this is where two different people's information has got commingled into the same chart. And he, over a 5-year period, he found that most of the errors were caused by a user, and only 2.5% of them were actually fraud, and 62% of those user errors happened in the ER, which I don't think would be surprising to most anybody, knowing the pace at which they are working and trying to get those people in the door and into a bed. Most of the overlaid records were discovered by the actual registration staff themselves, and about a third of them were through demographic data reports that their EHR system produces, which his team monitors on a daily basis. They averaged 9 overlays every month. And as Erin mentioned earlier, one mistake is a bad thing. But when you're talking about the severity of this kind of an error and how you could be treating the patient for the wrong disease or operating on the wrong body part or the wrong side, laterality, that's a really big cause for alarm. In 2015, the ONC also did a shared nationwide interoperability roadmap report. And in that report, they reported milestones for accurate individual data matching. So the ONC's guidance to organizations is that by the end of this year, they want organizations to have no more than 2% internal duplicate rate. By 2020, they wanted to have no more than 0.5%, and by 2024, they want it to be 0.01% or less. So those are some pretty big goals to try to achieve. One of the things that our company worked with the College of St. Scholastica on a research study where we analyzed almost 400,000 duplicates, so it was nearly 800,000 records. And we looked at trying to categorize just on key demographic data the data discrepancies that happen by each of those data fields and try to analyze patterns to draw the conclusions about what is the real underlying cause for the duplicate to have been created. And it was published in a research journal of the American Health Information Management Association last year. Next slide. Our findings showed that in looking at date of birth discrepancies, we have provider organizations have improved the date of birth data capture significantly in the last several years. 2007, when we analyzed it, there was almost 15% error rate on the date of birth, and now it's just slightly over 6%. I do think that that is a result of the Joint Commission's keen emphasis on positive patient identification. If you go to any provider organization, you go to a hospital, you go get a medication, whatever, it's very common for them to have you check your armband. Did we get your name right? Did we get your date of birth right? And so I do think that's been a positive outcome of the Joint Commission's efforts. There's other data, name discrepancies and genders has actually increased the data discrepancies in the capture of the patient's gender. I think what is most alarming is that 2 or more data discrepancies are found on almost 60% of all duplicate records. And that's a key point for when I talk about how algorithms and how most patient matching technologies that are based on demographic data get impacted when you have that many data discrepancies across basically name, date of birth, gender, social security number. Next slide. So certainly some of the things that, traditional solutions have always been, partner with colleagues in patient access to help with naming conventions, searching routines, and training and quality checking the registrars. I mean, those best practices for just day-to-day management are fundamental to improving patient identification. Certainly, the use of technology solutions like biometrics is a very critical component, and we're not going to solve the patient identity issue by any one silver bullet. It's not going to happen by anything individual, but certainly using more and more technology solutions are going to help us radically improve this problem. Working toward an enterprise solution, the goal of having one patient identifier for a patient is, a challenging goal, but it's absolutely necessary. And as a physician that I worked with at one organization said, if you have one duplicate, it's one too many, especially if it's your kid or your spouse or your parent or whatever. And personalizing it helps you understand why this is such a big problem. I mean, if United Airlines said, oh, we only crash an airplane once every, 100,000 flights. I mean, how many people would get on that airline? They wouldn't, because that's just too risky, and it's too risky for these patients. It's important to have advanced algorithms on the front and back end. And what I find, there's a lot of algorithms out there in use in the marketplace today, but they are not all created equal. And there is no such thing as a perfect algorithm, but some are better than others. And in the marketplace, you will see basic algorithms, which are algorithms that use exact or partial matches on a couple of demographic data fields. A lot of your EHR technologies out there, that's what they use. and a lot of registration systems, that's what they use. There are some that have use of intermediate algorithms, and they're using some fuzzy logic, and they are able to find, 50 to 70% of all the duplicates in that particular database. They're better than just the basic, but they still miss a lot of real duplicates. Advanced algorithms use mathematical and statistical theory. A lot of probabilistic algorithms are these. They may include artificial intelligence and some machine learning capabilities. And most of your best of breed types of EMPI systems are where you're going to find those. Just be cautious that a lot of companies will say we use probabilistic, and they really don't. It's the buzzword, so that's why they say it. But when you dig underneath the covers, you find out that it really isn't a truly advanced algorithm. Next slide.
Beth, if I could interject for one moment,
yes.
We did get an audience question before we move
Sure.
on. If you could define ONC that you referred to a few slides back, we had a question on that.
I am so sorry. The Office of the National Coordinator, so it's an agency under the Department of Health and Human Services. So it's a HHS agency, and it basically drives. You're welcome. Okay, so let's talk about a couple slides on solutions. Certainly a historical cleanup, it's always better to get your house clean before you start adding more data and more records to it. Patient matching optimization through some of the things that we've already discussed, staff training programs certainly, and then the use of technology, biometrics, and the workflow improvements that those types of technologies can help with in your organization. Next slide. Triggers to clean your MPI. A lot of times we see when somebody's implementing a new EHR, they're upgrading a system, they're acquiring a facility, or they are now joining a health information exchange, or they're becoming part of an accountable care organization, an ACO. Certainly those are very common triggers for what we see people wanting to do an MPI cleanup. Other triggers are data breaches, because if your demographic data is dirty in your database, you have the chance that you're sending claims and things like that out to the wrong patients or wrong organizations. Certainly, we've had just overwhelming volumes of duplicates that the physicians are complaining markedly about using the system because they just see so many duplicates in their system. And the worst trigger is some type of an adverse event. And I always hate when we get called because some patient died because they didn't have the complete record on a patient, and they are going through that either through a lawsuit or whatever, and that's the saddest situation for triggering a cleanup. Next. Talked a little bit about this already. Best practices for patient matching include having enterprise-wide data or information governance, policies and procedures that include naming conventions. How do you enter the patient's name? It seems simple, but it's not when you got compound names and names from patients that are from other countries. There's a lot more complexity to that than meets the eye. How do you search properly in that particular system? And that's very system dependent. So the use of when you don't know the patient's birth date, what do you put in? When you don't know the patient's name, how do you enter that? So having common and consistent use of default data. When you are migrating data, lots of good best practices around how do you get that data from one system into another and get it in there successfully so that it's used properly by the clinicians of the new system. And then how do you correct data? Because mistakes are going to always happen. So how do you do that? Having a centralized enterprise master patient index data integrity program is critical. Doing continuous access, continuous training of your patient access staff. You know, they only stay in that position 4 to 6 months. So you have to be constantly training and retraining those people. One thing I don't see a lot of is just collecting metrics on what are your error rates in your organizations and who and how are you reporting that? And is that getting reported up to a centralized governance committee? Certainly the front end use of advanced patient matching algorithms so that the registrar has the best chance if they have to search and when they have to search, that they have the best chance of finding the correct record. And then for those times when a duplicate has to get created because it's a trauma and the patient's unconscious and you don't have the information, how do you catch it on the back end so that it can get properly corrected in a timely fashion? And then the use of biometrics is, I think, going to be the standard in the future. Next slide. Oh, so I think from a standpoint of, you know, just having experts to clean up your EMPI, we do a lot of these types of projects. We have technology support. We are able to get this through projects done very quickly, very cost effectively. We know of an organization that had 27 facilities. It took them over 2 years. They hired 70 internal full-time equivalents to do it, and they estimated that it cost them almost $3 million, and at the end of the day, they still weren't done. So having a good experienced team is critical to supporting this program and process. And one that will give you good knowledge transfer, one that will feed back to you that your causes, what is unique about your situation, and how can you help prevent this in the future. And with that, I think I'll turn it back over to Aaron to wrap up.
Yeah, absolutely. I appreciate that, Beth. I appreciate everybody on the call and the questions that we're getting. And I am going to try to go through this next section a little quickly so we do have some time to answer some of your questions online. So first and foremost, how can we solve this, right? I mean, as a CIO, I was faced with this all the time. And, you know, first you can do what you're doing today, which is a lot of manual processes and in some cases having an army of people doing this manually, or really you could use technology. A lot of people have employed EMPI solutions, but that is not the end-all be-all. Dirty data is dirty data. That's where having a company, a third party like Just Associates comes in and really gets in there and cleans all that up to lower your dupe rate really helps. But you know, people often ask me, Aaron, what is it? What can we put at the point of care, at the point of entry to really streamline it? It comes down to biometrics. So, you know, really the best approach is biometric identification, clean everything up, and then streamline your workflow, because now you have 2 levels of cleanliness, a clean intake. I know this is Aaron, and my record is clean, and I can make a quick match very seamlessly. So I'm going to talk quickly about biometrics, because people oftentimes have seen the Minority Report and have seen all these wonderful movies out there that Hollywood has made, and they just don't understand what biometrics is. And really, I'm going to talk about our solution, and there's a number of solutions out there, but really our solution, because what we're seeing is that palm vein identification is absolutely the key into what people want to have happen. So today, Patient Secure has native integration with every major ADT and EHR system. We create really an enrollment that creates a one-on-one link with the medical record from multiple clinical systems. So if I show up, I put my hand on a quick scanner, I hover over it, boom, and I'm Aaron, and the medical record pulls up and identifies positive match. Number two, really it's, we securely and accurately identify the patients at the point of care. Imagine also if I'm passed out, right? Assume it's a trauma situation, if there's some modalities that really won't be able to get that because my eyes are closed or maybe something has happened where my face is obscured. Your hand is there, your palm vein is there from birth. So we found that most of the hospitals seem to like that modality. And then of course it retrieves the correct record from the appropriate clinical system. Also, what we're also seeing with a lot of our hospitals is that they have self-service kiosks. And we partnered with some folks to be able to provide this, and it really creates things very seamlessly. Imagine you walk in, and all you have to do is have your hand, and it pulls up, hey, this is Aaron, we're good to go. I mean, I can tell you that at my previous lives, when I put this in place, it made for identifying myself and my wife very quickly. And when we were there to deliver our second born, it was pretty much one of those, oh, she's in labor, oh, the baby's coming. It made things very quick. So a lot of hospitals are finding this kind of experience, and it's a win-win. Also from point of care, we've also seen a lot of hospitals doing this for things like oncology, making sure that your dosaging is right because it's, you have high levels of particular meds that a patient has to be on. Getting that right could be the difference between life or death. And then also, like I said earlier, with incoherent patients or unconscious patients, this has been a big win for a lot of trauma situations. From an adoption perspective, we really focus a lot on training. We focus a lot on the external, internal marketing within a hospital. We partner with the hospitals to make sure that it's not just technology. It's the whole system. It's end-to-end, making sure that things are streamlined. This patient identification cannot be allowed to stand and simply say, oh, technology, throw technology at it, that'll solve it. That's a piece of the puzzle. It's a major piece of the puzzle, but it's not the whole puzzle. All right, and last but not least, there's a case study. I'm not going to go through this in detail, but Scripps Health, huge health system in California, they reduced their medical record error rate by 30%. This will be out there for you guys to read and go through, and all of this information is available to you. If you have any questions and you want to schedule a demo, we're here to help you. Here's two links of two very distinguished people on my team that can assist you. But again, I really want to get to your questions. This is a major issue facing us, and this is important. So, Emily?
Thank you, Beth and Aaron. That was a fantastic presentation. So now we'll begin the question and answer portion of the presentation. As a reminder to our audience, you can submit any questions you have by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. So we'll try to get through as many questions as we have time for. And it looks like we have a lot of great questions rolling in. Our first question is from an audience member who is considering using Epic's recommended enhanced record lookup for front of house staff when they're looking up patients. So this product basically matches patients' names on partials. So you could type in SMI, JOH, and it would start to match up with names like John Smith. This audience member uses this technology in other fields of the EHR system, like medications, and they would like to know if you have any thoughts on the advantages and disadvantages of this.
Okay, I presume that's coming to me, Emily?
Yep.
Okay, no problem. So we partner closely with Epic and Cerner and Meditech and everybody. And so what we have found is that their solutions they have within the medical records are fantastic for within it. But as we were saying earlier, and as even Beth alluded to, the data is only good at the data, right? So if you misspelled my name, and you can imagine some people put my name as an ERIN, it's not going to come up. You're going to have issues there. So what we have found is a lot of our customers are using biometrics with the Epic tools to really make sure you mitigate the risk of misidentification down to almost a negligible number.
Perfect. Thanks, Aaron, for clarifying that. Our next audience question, when patients are queried, there's a weighted match that comes back. Are there any use cases or recommended workflows to prevent someone from accidentally placing data in the wrong patient chart?
Beth, you want to take that?
Yeah, I mean, certainly this goes back to the whole weighted thing is it depends on the algorithm that's used as to how trustworthy the weight is. And that specific question is going to be very dependent on what technology you're using. It's very hard to 100% prevent the user from grabbing something and entering something incorrectly on the wrong patient chart.
Perfect. Thanks, Beth. Thanks for clarifying that. Our next question, does the solution provide ID proofing capabilities? If so, how would it identify proof someone across EMR systems if the two systems do not have a common MPI number?
Yeah, so what we're seeing right now is a number of very, very large customers that we have are doing this amongst their hospitals and within their own IDN. It's a fantastic question, and that I can tell you we're happy to talk to you offline, especially with an NDA, and tell you some more about that. But we have very large customers using our solution with a number of different solutions, and there's more coming. So again, happy to talk more about this. Just reach out to us.
Thanks, Aaron. So our next audience member would like to know from either of you, in your experience, what biometric method has worked best in real-life examples?
Yep, and there's some fantastic case studies that are on the Imprivata website, and I credit our marketing team because they actually get real-world data and put it out there what's happened. So as is on our website and publicly available, the CIO for Adventist Health in Florida stated that palm vein was a tactile reinforcement of positivity for his patients because they felt like they were actually touching something, but it wasn't a fingerprint where it was associated with law enforcement. So it was actually a advantage for him in the area with competing against other hospitals. We've had other hospital systems come back to us and tell us that because the palm vein really can't be spoofed and you have it from birth, that there's a number of considerations when going into sort of an accountable care organization model and you're having patients traverse the health system and the different levels of care and continuum of care, and it seemed to be very, very seamless. Also, the modality is very simple. It's a plug-and-play modality, and it functions much like our iPhone functions, except it's not fingerprint. We also support other modalities. So for those who truly have a circumstance where it needs to be another modality other than palm vein, so be it. But to answer the question, palm vein by far is a leading winner in this case.
Thanks, Aaron. And this next question kind of segues right into that. What would the backup be if that hand happens to be the trauma point, so it can't be used?
Yeah, so I mean, I say this. I don't mean to be to sound any which way other than serious about it. There are two hands, right? So hopefully, you know, you're enrolled and you have both enrolled. If not, then there's other circumstances. There's backup process and whatnot. You know, by far though, we have not heard this issue come up from our hospitals, and we have not heard this be an issue. It's more of an outlier issue. But I mean, great question. But you've always got to have a plan B, right?
Yes, definitely. That makes sense. So we have a lot of great questions coming in. Just a quick reminder to our audience, if you have a question, you can type it in the control panel in the space labeled enter a question for staff. We should have time to answer all of your questions, and if not, we can answer them via email. So our next question is from an audience member who says, often MPI analytics or decision tree do not necessarily solve the problem of duplicate patients. Would a national registry separate from the healthcare industry as a gatekeeper who can perform third-party verification be a viable solution? So every verified U.S. resident would be registered and issued an NPI as part of the HIE initiative. What are your thoughts?
So I'm going to take a first step at this, and then Beth, I'm sure you have a lot of comments on this, especially given your experience with AHIMA. So I serve on a number of different panels and partnerships with the federal government, with HHS, and with the ONC, Office of National Coordinator. We've talked about this issue. As it stands today, there is a ban. There is a federal ban on HHS really being able to look into this issue. However, as I said earlier, breaking news today was they're potentially considering looking at this really heavily. There was, as part of the funding bill that was passed last year, an act for a federal agency to look into this and see what the effects would be of passing a national patient identifier. I think until those results really are out, it's kind of the jury is out. I think there's some great privacy considerations that need to be made, but from a hospital workflow operations, I can't imagine that it would be anything besides helpful having a national registry. But I mean, everything remains to be seen, and the data is the data, right? As we show here, there's a major issue, so something needs to change. And because of that federal ban, we have to move forward with putting in different levels there. And Beth, do you want to speak to some stuff?
Yes, This is a hot potato issue, as Erin mentioned. There's a lot of talk against having a national patient identifier. You know, the national patient identifier was actually a requirement of HIPAA back in when it was first issued in 1996. And within a couple of years that got pulled, and as Erin said, there's actually anybody that gets Medicare, Medicaid funding can't even study it. Now we're starting to get some easement of that, and so I think it would help, but you're always at the mercy of how accurate stuff is getting captured, and that just becomes one more place for inaccuracies to occur. So I think it's a double-edged sword as to whether or not it's a solution, and it could be one of many, as we mentioned earlier. I don't think there's a silver bullet to this. It's going to take a lot of many-pronged approach in order to solve this problem.
Thanks, Beth and Erin, for pointing out the nuances there. Our next question is interesting. It has to do with incorporating telemedicine. An audience member would like to know, how would the biometrics, such as handprints, be extended to telemedicine solutions, maybe by using a fingerprint via mobile device?
I can speak to this with experience, actually. So in one of my previous lives, we deployed telemedicine cards to rural schools because those kids were eventually feeding into our emergency rooms. And what we were trying to do is provide telemedicine for sore throat, earaches, whatnot, so the kid didn't get worse and suddenly present in our ED, right? We wanted to prevent those admissions, those costly admissions. So what we did is we did put biometrics at the far side to accurately identify them, because the burden was being placed on the school nurse, and he or she just didn't have the capability and wherewithal to really make sure that this child was indeed this person. So to the degree of it, there's a number of ways that this can be done. We're seeing a lot of folks do that. And again, in my personal opinion, it helped tremendously, and our telemedicine program was successful because of such.
Thanks, Erin. So our next question, are you aware of any facilities that require patient photos, maybe in the ER, in absence of a usual ID like a license or insurance card? So then when the patient is stable, he or she can then have the photo removed if they're able to provide a photo ID.
I can really only speak to my previous lives. We didn't have that workflow. Maybe Beth could speak to it some better, but I know that a lot of institutions require some sort of government issued ID that often they'll scan to the medical record. So I'm not personally familiar with that workflow now. Beth?
Yeah, I think you're right, Erin. I think there a lot of organizations require some type of photo identification that they scan in for the patient.
Okay, thanks for clarifying that. So our next audience member would like to know, are you able to interface with individual physician practices as part of the continuum of care?
So yes, in that if the electronic medical record is extended to those physician practices, then absolutely, there's ways to do that. There's ways to work with it. If they're independent, disparate one-offs that don't even have an EMR and aren't charting, I mean, we'll have to work through that and design things up. But we're seeing that right now with large IDNs. So again, without knowing the specifics of your question, I don't want to misstate an answer, but anything's doable. So just, shoot me a note, shoot us a note, and we're happy to talk more in details.
Thanks, Erin. So this next question also has to do a little bit with different EMRs. How would you recommend handling hospital mergers with separate EMRs?
Very carefully. No. So I've done this many times. I've migrated from one EMR to another. Oftentimes it's multiple EMRs to another. It's the most maddening experience as a CIO that you can possibly imagine, as well as for the clinicians. But number one, you really want to partner with the vendors out there in the community who's done that before. In fact, it's really funny you asked that question. That was how I partnered with Beth back in the day as a CTO because of that issue. We were migrating from one EMR vendor to another. We need to make sure that our records were clean and that on the intake process that the data matched up. We were seeing over 800,000 patients a year through our emergency department alone. So if you look at the volume of data that we were talking about, we're talking about, petabytes of data that we needed to make sure was appropriate. So you've got to partner with the folks who've been there before. You've got to partner with the folks like Just Associates, like Imprivata, that are helping hospitals do this every day. And then you got to have a good relationship with the EMR vendor and make sure that the other vendors have a good relationship with the EMR vendor at the end of the day to make this happen. It's more common than you know, and happy to share horror stories and war stories of things I've learned offline.
Excellent,
Beth?
thank you. Beth, anything to add to that? Okay, we'll move on to the next question.
I think Aaron covered it, yep.
Okay. Our next audience member would like to know what kind of bandwidth is required to store these images?
I will get back to you in the it's not like you need a asynchronous write with 5 milliseconds or less, which is what the EMR vendors require. It's not that required. It's not that arduous. I don't have a specific number off the top of my head. Happy to get it to you, but it's not arduous.
Okay, thank you. Our next question, who typically creates patient matching algorithms for individual healthcare organizations?
And Beth, I'm sure you're the best to answer this one. In my experience, it's always been a combination of health information management professionals plus the billing office and registrar's office and others. But Beth, you probably know best.
Yeah, the actual algorithms tend to be built by companies, but the selection of them and which ones you're going to use is based on the folks that Aaron described, obviously in addition to IT.
Thank you.
Thank you for the clarification. Right, you're right.
Okay, we'll move on to our next question. What is the best practice for correct patient identification at the ER, including retention of the same patient information and transmission of critical results of trauma patients at the ER into patient charts, transition of patients from the ER to an inpatient unit? So what is the best practice there?
Beth?
I'm not sure I'm understanding the question. I'm sorry.
Sure, I'll repeat. What is the best practice for correct patient identification in the ER?
Well, it's the same as what you would have for any kind of a patient coming in anywhere. But in the emergency situations, you have to get them typically in the door. The best practice is that's a whole workflow issue, and that's going to be very dependent on your location, your types of patients, and the systems that you're using.
Thanks, Beth. So we have time for just about 1 or 2 more questions. This audience member would like to know, what was the volume for the cleanup of the 27 facilities?
That was, I believe it was somewhere in the 300,000 to 400,000 duplicate.
Okay, maybe Beth, you can answer this too. What is the average length of time for an EMPI cleanup project?
That's an average, I would say, is 6 months, but they can be done in smaller, simpler situations in 6 to 8 weeks, and in large organizations that have hundreds of thousands and multiple systems that have to be fixed, it could take a year.
Okay, great. And that looks like those were all the questions we have today. Any final thoughts from Aaron and Beth?
Oh, I appreciate the opportunity.
Okay, well, thank you so much.
Thank you so much.
An excellent presentation, and thank you to our audience for participating. Please enjoy the rest of your day, and we look forward to having you join us for future webinars.